patients. And the first set of blood results were quite alarming. As you can see here, not only had her kidney function deteriorated, she also had profound hyponatremia with a sodium of 104. And the rest was all consistent with worsening renal function. She was acidotic. She had a slight rise in her white cell count, and she was hypoxic and had a combined respiratory and metabolic acidosis. Her chest x-rays here, and clinically and radiographically, this all fitted with pulmonary edema. So the team at this time, when they saw her in the emergency department, made the diagnosis that she had pulmonary edema, which had probably prompted the admission to the emergency department. Her kidney function had worsened, and they were not sure about this hyponatremia, whether it was drug-induced from the diuretics or whether there was any other reason. And then she had these lesions on her hands and on her toes, and they wondered about possibly vasculitis, maybe hepatitis C-induced cryoglobulinemia. So before you worry more about the diagnosis, clearly what became apparent then in the next few days was that she actually had endocarditis. And that was the main reason why she was so ill. But obviously there were the acute pressing problems. She was breathless, she was in pulmonary edema, she had worsening kidney function, and she had hyponatremia. In the first instance, the emergency team treated her with CPAP, gave her a dose of frusemide in hope she would deal with this would solve her fluid overload, and they started her on some GTN because of the pulmonary edema. And then she was transferred to the ICU for further management. By the time she arrived in the ICU, she had some frusemide with very little effect, and the team was hoping that this sodium was not 104 and that it was maybe just an error, and therefore it was quickly repeated, but turned out to be 105 on repeat. So the key question is, and this was a real patient who was now in the ICU Friday night at around midnight. How would you manage her fluid status? What would anybody do? Nothing is not an option. Sorry? Anybody? Over there. You have to do something. I mean, she's breathless, she's in pulmonary edema.
As you have displayed, she is oliguric also, because the urine output is steadily dropping. We need to manage her sodium, we need to manage the volume, we need to take out some solutes because there is an AKI. So I would definitely go for a dialysis. Mm-hmm. And as the blood pressures are high up, I would like to stop the nitroglycerin, shift her to an emergency dialysis, maybe starting with an isolated ultrafiltration to improve her oxygenation, and then do some solute control.
Okay.
With some sodium profiling. I don't want to jump sodium to 135 directly. I would be a little slower on that.
Excellent. You've already summarized the management very well. I fully agree. She needs some extracorporeal fluid removal. She's failed diuretics. There were some discussions whether we should just give her some saline or highly concentrated saline to just get her sodium up. All of this would have made her pulmonary edema worse. And frusemide she already had, and a higher dose was unlikely to be effective. Now, you've already highlighted the issues with renal replacement therapy. So if you give her renal replacement therapy, how do you deal and how do you manage this low sodium? And here are some potential options, what people could do. And I think apart from the first one, all of them are possible, and I go through this. But using CRRT with standard replacement fluid and using it for 24 hours without any adjustment would be harmful. All the other options we can go through. And the reason this could be harmful is because all the various commercially available dialysis or replacement fluids have a sodium of 140 or 136. There's very few which have a sodium of 136. But there's no commercially available fluid with a sodium of less than 136. And here are just the most commonly one. As you can see, 140 is the standard sodium concentration in a CRRT fluid bag. And that's important because sodium, like urea, gets exchanged very rapidly. So sodium and urea have similar solute transfer characteristics. So if you, without making any adjustment, the serum sodium would quickly equilibrate and the patient would have a serum sodium of 140 if we use a standard bag. So there are different options, and I put it to you that you need to have some plan in place or something in your mind how you would deal with this when the situation arises. Not often do we see patients with a low sodium in this range, but they do occasionally present to the emergency department or to the ICU, and in this case it's absolutely vital that you have a plan. Sadly, in our institution they seem to come mainly at weekends and often out of hours, and that's why it's even more important that we know how to manage them without causing harm from CRRT, for instance, if the sodium rises too fast. So one way of doing it is using the standard bags and adding dextrose 5% at the same time. And this was described in one of the reports in CJSON a few years ago. And the way it works is outlined here. So you use your standard bag, your 5-liter CRRT bag, use CRRT according to your prescription, and then add dextrose 5%, which is essentially water, to the circuit, to the line before the blood returns to the patient. Now the question is obviously how much dextrose would you give? And there's another picture showing this. So dextrose 5% added to the return line before the blood reaches the patient. Now to calculate how much you would give, we actually have a formula. I don't remember this formula, but I know where to find it. And you, again, I would put it to you, you need to have some idea where to find these formula if you need them in an emergency. And this is the formula to give you the rate of dextrose 5% in this situation. So if we use this case, so she had a serum of 105, we would not want her serum sodium to rise above 115 in 24 hours. So the cutoff usually is 12, but if we stay at less than 10, I think we're safe. So if the target sodium in 24 hours should be 115 or less, we know the CRRT fluid sodium is 140, and we plan to clear 2 liters an hour. In this case, for the first 24 hours, she would need a dextrose infusion of 435 mL per hour. Now, obviously, this changes because hopefully after 24 hours, her serum sodium has gone up and would be in the range of 115, maybe, hopefully. And then we would, again, adjust the dextrose infusion and would probably need much lower rates. But that's a way of safely correcting hyponatremia during CRRT. It goes without saying that you would regularly check her sodium and that you would regularly adjust if necessary. Another way of doing this is by manipulating the sodium in the CRRT fluid bags. And this, again, can be done because the bags, which are 5-liter bags, have room for almost up to another 2 liters. So it is possible to say, well, if we just had a lower sodium in the CRRT fluid bag, we could provide CRRT safely according to our protocols. And you can manipulate the sodium concentration by adding water to this bag of 5-liter bag. And you can add sufficient amounts of water so that the sodium concentration in the CRRT fluid is in the desired range. So in this case, 115, because then the serum sodium would never rise above 115. Just to show you how this can be done, so this is the normal composition of a CRRT fluid bag with a sodium of 140 in 5 liters. So it means there are 700 millimoles of sodium in a 5-liter bag. If you just, for example, added 150 mL of sterile water, you would add you would increase the volume to 5,150. You would still have your 700 millimoles of sodium, and that gives you a concentration going down to 136. If you add more sterile water, then you gradually dilute the sodium, and you could get to your desired sodium concentration. So if you, for instance, in this lady aimed for a sodium concentration in the CRRT bag of 112, given that she has a sodium of 105, then you would have to add 1,250 mils of sterile water. And this can be done. This can be done by pharmacists in the pharmacy department using a sterile technique. And in some hospitals, it can also, it's been allowed to be done by the clinical staff, the doctors or the nurses, again, using a sterile technique. And this is what was done in this particular scenario. And as you see, if you do this and step by step, every day, adjust the sodium concentration in the fluid bag, we managed to gradually increase her serum sodium and do this at a safe rate, and also provide renal replacement therapy, which she needed, and remove excess fluid to the point that she didn't have to be intubated. In some hospitals, as I've said, some teams are allowed to do it themselves at the bedside using an aseptic technique, and in other hospitals, it's done by the pharmacy department. Another option would be to, if you didn't have the facilities and you didn't have the approvals to do this, and the pharmacy department couldn't do it, and for some reason you didn't have dextrose 5%, which you could do, as I showed you at the beginning. Another method, less reliable and less predictable, is to do very short periods of RIT with very frequent monitoring of serum sodium, so 2 hours and then stopping to let things adjust again. But these are, as far as I know, the only ways of providing renal replacement therapy in patients with a low sodium in a safe manner without causing harm from overcorrection and over-rapid correction. Now, the same can be done if you've got somebody who needs renal replacement therapy and has a sodium which is too high, say 165 or 70, which you don't want to correct too fast. Same principle applies, so we're using bags with a sodium concentration of 140. If you use them in a patient with a sodium concentration of 165, you would rapidly correct the sodium, so from 165 to potentially 140 in a short space. If you want to adjust or modify the sodium concentration in the CRRT bag, it can be done by adding concentrated saline. And again, just as an example, if you add small amounts of hyperconcentrated saline, in this case 30% saline, which is available in pharmacy, in pharmacy departments, then you need very small volumes, and they would lead to a significant change in your CRRT fluid bags. And in the case of a patient with a sodium of 165, you could add 20 mils of concentrated saline, have a sodium concentration in your bag of 160, and then you could safely provide CRRT. So in conclusion, we all know that over-rapid correction of sodium disorders is harmful. In patients who need renal replacement therapy, it's essential to have a protocol in place, whatever this protocol is, whether it's adding dextrose or manipulating the bags, but you need to have something available to know what to do when the situation arises. Thank you for your attention.